All right, I think we should get started. I'm very delighted to welcome Harsha Thirumurthy from Penn, who is an economist and scholar and has done really fascinating, I think some of the pivotal sort of work in global health and behavioral economics in general, but especially around HIV. And when I think about my behavioral econ course that I teach, Harsha's papers are everywhere. So and thinking, and so I'm really excited to have him join us today. And also congratulations on finishing third in your age group in the Boston Marathon, which is really cool. And I need some tips because I'm running my first marathon this year. So you can give me a couple ways of clapping, but I think it's very cool. So I will leave it to you to take it away from there. And we'll do clarifying questions as we go along. So you can raise hands, folks, or put a question in the chat if you want to, and I can sort of circulate it back to you, Harsha, if I see any questions in the chat, and then we'll leave time for discussion at the end. So take it away when you're ready.
Okay, wonderful. Thanks so much, Maggie, for the introduction, for inviting me to share my work with all of you. So thanks everyone for being here. Yeah, before I dive in, Maggie, I'm happy to chat marathon training at any point in the future. It's one of my other hobbies. Aside from this work I do in HIV prevention. Thanks so much again, everyone, for being here. I'm delighted to have this chance to present to you results from a big project that we completed, fortunately, literally a week before the COVID-19 pandemic began. We're extremely fortunate that we didn't experience any of those disruptions to this 3-year-long study. And I will be talking to you about a project that's looking very carefully at how individuals in Kenya who are at high risk of HIV infection respond to the availability of HIV self-tests. Now, I think there's been a lot of interest in self-testing over the past 2 years, particularly with COVID, and perhaps one of the things this talk might do, in addition to providing some insight on HIV prevention and self-testing, is that it may also help us think through how COVID self-testing might be affecting people's behavior. So there's some interesting parallels there. This is a joint work with a number of different collaborators from different disciplines. Kawango Agat, a longtime research partner of mine in Kenya from the Impact Research and Development Organization, has been very closely involved in both the formulation of this project and its implementation. Sue Napierella, who's an epidemiologist at RTI International. Ruchi Mahadeshwar, who's fortunately joining us here by Zoom. She is a PhD student in economics at Brown. And Suzanne Maman, who's a health behavioral scientist at UNC Chapel Hill. Let me motivate this work before I tell you about what exactly we did in this project, by drawing attention to the topic of transactional sex and its role in driving the HIV epidemic in sub-Saharan Africa. The figure here shows you recent estimates of subnational HIV incidence among adolescent girls and young women, or rather I should say among young women specifically, 20 to 24 years old. And you can see that in some parts of sub-Saharan Africa, particularly Eastern and Southern Africa, we're still observing extremely high annual HIV incidence rates, exceeding 1% and even reaching as high as 3, possibly even 5 or 6% in some parts of the region. And this is a major concern given just the size of the population of young people in the region. And one of the reasons why we're seeing such high risk of HIV is that adolescent girls and young women do engage in sexual relationships with partners who are typically older than them. And that's contributing to transmission from older men to younger women in many of these countries. So we're seeing age disparate sexual relationships that often have a transactional element to them. So it's not always necessarily economic compensation. It could be compensation as gifts or as material expressions of love between partners. But nonetheless, there is a transactional element to these relationships, and that's one reason why we're seeing HIV risk persist. There's two reasons why, in my view, why it's really difficult to reduce HIV risk. This is something everybody wants to do, obviously, in this population, but it's hard. It's been hard to do and hard to accomplish because of several aspects of transactional sex in age-disparate relationships. And the two that I want to highlight here is that, you might think, well, why are we not able to reduce the risk associated with these relationships through condom use, through partnerships with younger men or peers for young women? And one reason is that there is a trade-off that women face between taking on lower risk, taking on less risk through, say, condom use, and earning more income. So if they want to accept lower risk, there's a lot of data suggesting that there's often lower income that will also result from that. So if you have situations where women need to earn more income, that need to take on more risk in order to earn more income is a major factor. The other is that women often don't know the status of their male partners. So again, it makes it difficult to reduce risk if you don't know the status of the partner with whom you're engaging in transactional sex. So these are both things we want to keep in mind as sort of general features of what's going on in the setting where we're doing this research. Now, this project is going to focus on HIV self-testing as a potential solution. I want to underscore the word potential here, because this is really what we're trying to assess in this project: is what is the scope for these new diagnostic technologies to influence people's decision-making and hopefully even reduce their HIV risk. And so let me walk you through why we think there's even some scope for that in the next two slides. So first of all, what is HIV self-testing? This is a form of testing whereby people can essentially collect their own sample and learn their status privately in the absence of a provider. There are several different types of HIV self-tests that are out there at the moment. The one that's very common that has also been FDA approved and WHO pre-qualified is an oral fluid-based self-test. So the user in this case would swab their gums and would be able to learn their HIV status within 20 minutes. There's been a lot of implementation of HIV self-testing, both in research and non-research settings in many parts of the world, including sub-Saharan Africa. And we've seen very high acceptability, in part, I think, and high demand as well, in part because this is a much more convenient way for people to learn their status, particularly populations that are reluctant to go to a clinic either to take the time or to perhaps experience some of the stigma associated with seeking health facility-based health services. And since the WHO recommended scale up of self-testing, we have seen a number of countries operationalize self-testing into their guidelines for HIV testing, and they're starting to scale up self-tests. What we've pioneered in research, say, over the past 5 years, particularly formative research that led to the trial that I'm going to talk to you about, is an approach that we've called secondary distribution of self-tests. So the idea here is not so much to sort of go into a community and give self-tests individually one by one to people who may benefit from learning their status, but rather we've explored the potential for equipping people who are at high risk, in this case women, with multiple self-tests so that they may be able to not only learn their own status, but also to then initiate HIV testing with their male partners, both their current male partners, but also in some contexts, maybe their potential male partners as well. We did a lot of work to first establish, is this feasible? Is it safe? Because introducing HIV tests in the absence of a provider may convey some risks to the women in particular. So we've done a lot of data done a lot of work to first establish that in fact this was feasible, that women were very interested in acquiring self-tests, that they were able to initiate self-testing safely with their male partners. And we also had some formative research and pilot studies that suggested this was effective in increasing partner testing rates. So the question then that gave rise to, and this is really what we're going to focus on in this talk, is what are the potential benefits of having access to HIV self-tests for women who are at high risk of HIV infection. That was a question that had not been answered prior to our initiating this study. So what are we going to do to answer that question? What I'll talk to you about today is a cluster randomized trial in Kenya that was conducted among women who are at high risk of HIV. In the intervention clusters in this trial, women had access to free HIV self-tests over a sustained period of time. And what we're going to be looking at is a number of different outcomes, and I'm deliberately going to have to speed through my presentation of some of our results given the time constraint, but we're going to look at, first of all, does this actually enable women to learn the status of their male partners? And then we'll also take on the bigger question of whether it then helps the women reduce their own HIV risk. And the part of the project that I'm going to talk about in more detail today, hopefully, is what effect this technology, access to this technology, has on women's sexual behavior, on their economic outcomes, given that many of these women are engaged in relationships that have a transactional element. So we're going to be particularly interested in figuring out whether learning the status of partners is affecting women's sexual behavior, as well as their economic decision-making in transactional sex encounters. So some of this work has been recently published, and I'm going to deliberately speed through that part because I'll refer you to the paper that we've published from it. But then the second part of this, the goal of this project about the effects on sexual behavior and economic outcomes, is very much work in progress, and I really welcome your feedback on it. I think we're contributing in this work to a number of different strands of the literature, both in public health as well as in economics. So let me just focus here at the beginning on the economics, focus here on the economics contributions. The first is we're speaking to a question that's been out there in the literature about how people respond to receiving information of various sorts. So the information can be diagnostic information about one's own health status. So there's been some work done on how people respond to figuring out their own HIV status. And then there's been information, research done also on how people respond to getting generalized information about the risk of a disease or prevalence of a disease in a certain subpopulation. But I think the missing link here, and I think the real innovation in this work that we're doing, has to do with the fact that the technology of HIV self-tests is enabling women to not only figure out their own HIV status, but rather it's actually helping them figure out very specific information about other people's HIV status, right? So about specific partners that they have, which I think is something that prior to the advent of HIV self-tests, really it was difficult for women to learn that status of their partners. There's also a lot of work in economics that's been done on transactional sex markets, so to speak, and how risk is associated with income. And you'll see that we certainly will be focusing very much on what the consequences of taking on more or less risk are for women's economic decision-making. And then lastly, I think particularly in the HIV prevention community, this contribution to the goal of increasing male partner testing and increasing knowledge about HIV status is one that's been quite important. So through this work, we've been able to really establish and explore whether self-testing can play a role in ongoing efforts to expand coverage of HIV testing in settings like sub-Saharan Africa. There's also been some interesting work done on how this particular use of self-tests, i.e. where people are using it in their sexual networks, may affect decision-making. And I just want to reference here some of the really pioneering work that was done just here in the US when self-tests first became available by Alex Carballo-Dieguez, who's done a number of studies with men who have sex with men and explored how access to multiple self-tests might affect decision-making in those populations as well. So it's an important reference for this work. pretty sure, looking at the time, I'll run out of time to go through all of my slides here. So let me just give you a preview of what we find. One is that giving women access to sustained access to HIV self-test does result in significantly higher rates of partner and couples testing. This is the work that we've published recently. Does not have any effect on HIV incidence, which you'll see remains fairly high in this population that we study. And then the work that's in progress right now that I want to really unpack in more detail in today's presentation is showing that access to the self-test does, however, influence women's sexual behavior and their income. And you'll see some very interesting ways in which women are able to use self-test to not only avoid riskier sex with partners who test positive or even partners who decline testing, but also in a somewhat arguably kind of unanticipated way, they're also reducing their condom use and earning more income from partners who are testing HIV negative. And that overall, this intervention is actually enabling them to earn more income from transactional sex. So that's the kind of intriguing result that I would like to talk through in more detail when I show you the data. So let me dive into giving you a brief synopsis of the randomized trial. And then I'll summarize the main effects that we have on partner testing and HIV risk. And then really I'll save the bulk of my remaining time for this work on how partner testing, learning partners status is affecting sexual behavior. Can't see the panel with the chat, but if there are any questions, just please let me know. So I want to reference at the outset the paper that we published last fall in November that reports the main effects of this intervention on partner testing and HIV incidence. So I'll deliberately give you just a very brief summary of what we find there. It's helpful background to have when I tell you about the paper that's really in progress right now with Ruchi and with Kawango, that's looking at how learning of partner status is affecting women's sexual behavior and economic decision-making. So the randomized trial was, again, described in more detail in the paper that I just mentioned, but this is done in Western Kenya in Siaya County, which is in the Nyanza region. It's a setting with very high prevalence of HIV, exceeding 15% by recent estimates, and also high incidence among adolescent girls and young women. So keep in mind that the goal for ending the HIV epidemic is to bring incidence down to below 0.1%. So incidence is at least 10 times higher than what the sort of disease elimination targets are at this moment. The trial design is a cluster randomized trial. So we had 66 pair match clusters from communities that are along Lake Victoria, where transactional sex is very common, as well as market centers where, again, we see a lot of transactional sex happening. We're sampled 30 women from each cluster, and the eligibility criteria were that women had to be older than 18 years. They underwent an HIV test and were HIV negative at baseline. And because we were interested in HIV incidence in this population, and they also had to self-report 2 or more partners in the past 4 weeks. A number of reasons for that criterion, including that we're trying to target the intervention to high-risk women, given that the government is particularly interested in making self-tests available to people who are at higher risk, rather than necessarily to anyone in the general population. And also that women who self-report 2 or more partners are also just much more likely to be engaged in transactional sex. In the intervention clusters, women had sustained access to self-tests, so they were given 5 self-tests initially, and they could receive more on a 3-monthly basis. They were all trained on how to use self-tests. We had piloted these procedures before the study. And again, we had piloted prior to the study a counseling intervention in which women were encouraged to use the test themselves frequently, but also to offer the self-test to their current and potential partners, using their own discretion and trying to focus on people whose status they did not know. So that was the general counseling that was given to them. In the comparison clusters, we had a relatively passive intervention whereby women were essentially told that partner testing remained important and that free HIV testing was available at public sector clinics in their communities, and they were given some generic referral cards that were designed to encourage them to seek HIV testing. We had a follow-up with women at 6 monthly intervals for up to 24 months. And at each of the 6 monthly intervals, all of the women in the study were tested for HIV because we were interested in measuring the primary outcome of HIV incidence. So for all study participants, we are assessing HIV status and measuring incidence. We also looked at a number of different secondary outcomes related to partner and couples testing, identification of HIV positive partners, and also a number of questions pertaining to sexual behavior, including in the most recent transactional sex encounters. And IPV is another outcome that was assessed. So this is the part where I get to summarize results that we've already published. There were a total of 2,086 women who were enrolled, a mean age of 27 years, median of 24 years. About 65% were married, and you can see that women earn a median of $30 per month in income. A few key features to highlight with regard to sexual behavior and transactional sex. You can see that it's very common in the study population. 81% regularly exchange sex for money or material goods at baseline, and 16 and 51% of participants are reporting transactional sex as either a primary or a secondary income source, respectively. We're also seeing that, remember I mentioned at the top of the presentation that knowledge of male partner status remains limited. So only 42% reported that their primary partner, 42% reported that their primary partner had not tested in the past 12 months. So there's not a lot of awareness of recent HIV status for male partners. And condom use is not, it's certain, there is certainly some condom use that's observed and reported. It's 36% report condom use at last sex, and it's a little bit higher transactional sex encounters. And it does speak to the progress that's been made in promoting condom use in this population. It's consistent with the data we've seen from other national surveys as well. In the intervention group, women received about 17 self-tests over this course of the study. So you'll see that initially they were given 5, and then they received an additional 3 self-tests in the first 3 months. But then over time, because women, not all women have a large number of sexual partners, we see that over time, the number of self-tests that they're receiving does decline. But altogether, it's still a substantial number of self-tests they get. And 47% of the self-tests that they received were reported to be distributed to their sexual partners. Again, these are results that were presented elsewhere in the previous paper. We're seeing a big effect of the intervention on primary partner testing. So you can see that in the intervention group, more than 80% of women reported that their primary partner tested for HIV in the past 6 months, compared to less than 50% in the control group. So a big effect on partner testing, consistent with some of our pilot data showing that this intervention does make it a lot easier for the women to initiate testing with their male partners, and also that the male partners are very open to getting tested as well. We see a similar effect on couples testing, again, published previously, so I won't talk about it in more detail, but just keep in mind that what this intervention is doing is it's enabling women to learn the status of their partners, and it's also enabling mutual disclosure of HIV status. We'll talk about what's happening in the transactional sex encounters in the next part of the presentation. There's a big increase in the number of HIV positive sexual partners that were identified over the course of the study. Again, in the intervention group, we're seeing many more HIV positive sexual partners being detected than in the control group. I might as well mention one of the limitations of the study at this point, which is that by design, we did not focus on assessing linkage to care and treatment outcomes in this trial, but that's an important question that we're starting to look at next. Again, not a central part of this, the remainder of this talk that I'm going to tell you about the transactional sex encounters, but we did report earlier that incidence was not significantly different between intervention and control groups. So you can see that overall, the incidence per person year of follow-up was 1.1 per 100 person years, and slightly higher in the intervention group, but not significantly different. Let me pause there before I basically go to this last and final part of the presentation, where I want to tell you about the work that's in progress right now on how the intervention is affecting sexual decision making. Okay, so this is one of the exciting kind of subcomponents of the study. Really enjoyed diving into these data with Ruchi and with Kawango, because the main study results kind of showed us some intriguing and important results. You know, that the intervention's helping women learn their partner status, but that it's not, and it is identifying more HIV positive partners, but it's not necessarily having a large enough effect to reduce HIV risk. So we were curious as to what was happening with the partners that the women are having transactional sex with, and that's something we did not study earlier in much detail. So what we had done in this study is at each study visit, women were asked about their 3 most recent transactional sex encounters. And we did this particularly because we were interested in how the self-tests were being utilized in these types of encounters. So over the course of the study, we ended up having data on 11,000 recent transactional sex encounters. And for each of those encounters, we had some data on partner characteristics, particularly the age of the partner. We didn't have a lot more data on the partner, except at baseline when we did ask a few more details about the partner. But keep in mind that the partners may be changing over time. And also we asked a few questions about the encounters themselves. So substance use, whether the status of the male partner was known. So did they take an HIV self-test? Did they go to a clinic for an HIV test? We also asked about condom use during the encounter. Was a condom used or not? One of the key outcomes we're interested in is whether the women knew the status of the partner with whom she was having transactional sex with that specific encounter. So was the woman present when the partner used an HIV self-test that was in the intervention group, or did she go along with her partner to a clinic to learn the status of to learn his HIV status in the control group? We also asked about what was exchanged in the encounter in terms of not just money, but also gifts and other services and other in-kind transfers. So we look at compensation that was received and attributed to that specific encounter. The empirical strategy, what we're going to do, and the results that I'll be presenting to you, there's sort of 3 key types of models that we're estimating here. The first is just the intent to treat effect of the encounter of access to HIV self-tests on encounter level outcomes. So what is access to HIV self-tests doing to knowledge of the transactional sex partner status? What is it doing to condom use, and how is it affecting prices? So this is essentially an OLS regression where we're interested specifically in the coefficient of this HIV self-test intervention assignment, which was randomly assigned, and we're clustering standard errors at the study cluster level. The other thing we're interested in at the participant level, so the first set of models is run on the encounter level data on those 11,000 encounters. We're also going to look at the participant level. How is access to HIV self-tests affecting the health outcomes of the women, as well as some of their economic outcomes? So I already told you about the main effect on HIV incidence, but we'll also be looking at a number of different self-reported outcomes. And then finally, we're interested in the mechanisms by which this intervention may be affecting outcomes of transactional sex encounters. And there, what we're going to be doing is using the random assignment to an HIV self-test intervention as an instrument for whether or not the participant learned the status of the transactional sex encounter. So essentially, what we'll be looking at is using an instrumental variables approach. What is the effect of learning the status of the male partner on the likelihood that condoms are used and on the encounter prices that are associated with that encounter? Okay. So I'll walk you through these results in order, and then I can wrap up hopefully with sufficient time for discussion. So just a few key things that I want to point out about these transactional sex encounters. One is that the age gap here, if you notice in the second row, it's about a mean of about 5 years. And this is kind of consistent with what I had said to you earlier at the very beginning about just how common it is for there to be age disparate partnerships, particularly among young women. And this is also consistent with other data we've seen from the region. And you can see that in almost 50% of the encounters, the partner is at least 5 years older. So in general, we would expect the male partners to be older, but the 5-year gap is quite substantial and notable. You can also see that at baseline, we did have, as I said, we collected more data on the partner characteristics at baseline. So one of the questions we asked the women is whether they thought the partner was HIV positive, and there is certainly like a belief that the women have that the partners are high risk. Some of the partners are high risk, and then also condom use correspondingly is also quite high in these encounters. And then you can see that the encounter prices here are quite substantial. So a mean of $13, $13 to $14. I'm going to skip over this summary of the encounters that we observed in the follow-ups visits and just move to the main regression results, which will tell you the story. So the first thing to point out is that we are looking at all of these encounters and we're asking whether the intervention changed some of the key features of these encounters. So what we're showing in this table is the effect of the intervention on knowledge of the transactional sex partner's HIV status. And you can see that the intervention significantly increases knowledge of the transactional sex partner's status. This is consistent with what I presented to you earlier about the intervention affecting knowledge of the primary partner status. So this isn't necessarily a surprising result to us having looked at the primary partner data, but still it's notable that even in these transactional sex encounters, the women just are able to now figure out what is that partner status. There is a decline in condom use in those encounters. It's not statistically significant, but it's notable that it's about a 5 percentage point decline. And then when we look at the log of the encounter price, there's about a 9% increase in encounter prices. Again, consistent with that risk income trade-off, where if you reduce condom use, the women are more likely to, they're likely to earn higher income as a result of lower condom use. And in the paper that I referred to, the working paper, we actually have a theoretical model that explains how, why we would expect this encounter price to be higher, even if there's lower condom use, when there is lower condom use. And we also importantly are able to show that you would expect a higher encounter price when condoms are not used, even if the woman is able to learn the partner's HIV status. So there's a premium that would be associated with both higher STI risk, which obviously the HIV self-test does not eliminate. And also the men have a higher willingness to pay for condomless sex. And so that would also explain this higher price. What's striking in the results in the analysis we've done so far is that when we look at higher risk partnerships, now what we're calling higher risk partnerships are partnerships between young women, so women who are aged less than 24 years, and partners who are more than 5 years older. So these are what many people would agree, and even the literature confirms, are the highest risk partnerships. It's why we see extremely high HIV incidence among young women in Kenya and other countries. When we look at these higher risk partnerships, what we're seeing is that as a result of the self-testing intervention, there's not only higher learning of partner status, but there's also like a bigger shift away from condom use. So this 10 percentage point decline in condom use, which is very substantial. These were relationships where in the past, prior to the intervention being self-test being available, women knew that these were higher risk partnerships, so they may have been more likely to use condoms in those partnerships. But now, having learned the status of those partners, particularly those who are HIV negative, there's much less condom use. And in exchange for that, there's also higher income that the women are earning in those encounters. When we look at lower risk partnerships, we're actually seeing a much more muted effect of the intervention. So it's consistent with this notion that the intervention is leading to a reduction in condom use only when encounters that used to be previously high risk are now established to be low risk because the women have been able to find out that in fact the partner is HIV negative. What we don't see in our transactional sex encounter data are this sort of other margin in which the women are changing their behavior, which I also want to draw your attention to. There are many partners who test HIV positive or who may decline to even accept a self-test. And in those cases, what the women are reporting is higher condom use when the partner tests positive, or when he refuses to use a self-test, or when he refuses to go to a clinic. That's much more likely in the intervention group. And also, they're also more likely to decline to have sex altogether in these cases. So the fact that the intervention is actually resulting in some of these higher risk encounters becoming lower risk because of either condom use or no sex at all, I think is quite striking as another way in which the intervention is changing behavior. It's also just worth noting in this third and fourth column here that there isn't any effect that the intervention is having on the number of encounters that women are reporting, or even the number of partners that they report. So that's an interesting result as well. And then finally, just when we this is kind of the last of the intent to treat results, when we look at what the intervention is doing to this other dimension of behavior that's really important, which is economic behavior, we're seeing that the intervention does result in higher monthly income. This is not a significant effect, but it's still it's striking that it's a positive effect on income, and that the income from transactional sex in particular is 11% higher. So as a result of less condom use that we reported earlier, and the higher prices from those encounters where condoms were not used, we're also seeing this translate into overall income that women reported being higher. I'm skipping over this part, it's in the paper, but we're also showing that the intervention is not affecting self-reported STI risk or IPV or pregnancy. So these are outcomes that we would be particularly concerned about, because HIV self-test might enable women to learn the HIV status of their partners, but it still leaves open the possibility that unprotected sex would be associated with higher STI risk or pregnancy risk, and we're not seeing that to be the case in the self-reported data. Just one of the, I guess the concluding point is about the key mechanism by which we think these effects on condom use and encounter price are flowing through is in fact learning the male partner status. So when we do these are the instrumental variables analysis results, where we instrument for whether or not the women learn the partner status with assignment to the self-testing intervention. As I showed you before, the first stage is very significant there. What we're seeing in the full sample here is that, yes, indeed, learning that a partner is HIV negative, because we limit the analysis here to the negative partners, is associated with lower condom use and higher encounter prices. Particularly when we include the controls, it's a significant increase. And that when we focus on the high risk encounters among adolescent girls and young women and their older partners, that's when we see the really big shift in condom use, the big reduction in condom use, and the very large increase in encounter prices. So we're seeing about a 44 percentage point decline in condom use as a result of learning that an older partner is HIV negative. And we're seeing a corresponding increase in compensation for those encounters. Another mechanism that, again, I'm not going to report in the interest of time here, but we are also looking at the possibility that mutual disclosure is the key mechanism through which behavior change is happening. And in fact, what we see is that when the women also reveal their status to the male partner, these effects are even larger, right? So when the women reveal she's negative, the effects on condom use are even more negative, and the effects on prices are even higher. There are, just gonna point out that we have a qualitative study that's in press that really is, in a very reassuring way, is confirming some of these quantitative results that we're finding about how women use these self-tests. One of the interesting points that the qualitative interviews has revealed is that the women really do view these self-tests as a way for them to learn their partner status and even to earn more income from the partners that are proven to be quote unquote safe. So they know that those men would rather have sex without a condom. In the past, they would typically insist on condom use because they didn't want to take on the higher risk. But now they're willing to shift towards condomless sex in exchange for the higher income. And again, an intriguing behavioral response. So just have 2 slides to conclude, and basically to point out that overall incidence is still quite high. That's a concern for us. A couple of theories as to why the intervention may not have worked. One possibility is that there's still a lot of partners out there that the women are not testing, who may be may still be presenting a high risk to the women in terms of HIV. And I mentioned that we didn't look at linkage to care. But overall, just want to wrap up by saying that this intervention does seem to have a big effect on knowledge of male partner status and identification of positive partners. In Kenya, WHO, and other venues where we presented these data, I would argue that this finding has been most intriguing and interesting to policymakers. From the economic side, I think it's very intriguing that the intervention, actually, the women view the intervention favorably because it offers them an opportunity to avoid this trade-off between more risk and higher income, or more risk in taking on more risk in order to earn more income. And that, I think, is something that they appreciated quite a bit. But we still, I think, at the end of the day, are left with the important challenge of needing to identify additional HIV prevention interventions for this population that still remains vulnerable. Let me just pause there, and I'll stop there for questions and discussion at this point. Just want to thank all of the various collaborators.
Terrific. Thank you. I think this is really, really interesting. And I'll let people sort of gather their questions. People, you can raise hands, or if you rather not, you can put them in the chat. But I'll start with a question. I think the results around sort of earnings are, I think, especially intriguing and interesting. And I wonder if you can sort of reflect in a big picture sense on whether you think the intervention is sort of welfare improving, in a broad sense, and how you would know that. I think the data that you've collected obviously is able to say a lot more about that than in the absence of knowing, for example, that there were these economic benefits. But I guess I'd also be curious about other ways to think about that, measuring sort of anxiety, depression, or like sense of control. I think so much of your results make me think about sort of who has the power in these transactions and sort of issues of, control. And so, I also think about sexual violence or other sort of outcomes that would help get at some of these, like, important questions around whether the sort of intervention is welfare improving, and particularly for the main participants.
Yeah, Maggie, that's a really good question, and something that we've been talking about a bunch. I guess, I think like our qualitative results really do suggest that this intervention is something that women really value. And so to the extent that we want to base one answer could be just driven by the qualitative interviews. We feel like there's a lot of enthusiasm for having this access to self-tests, and that the women are finding this very empowering because it enables them to find out the status of their partners, and it enables them to make more informed, better informed decisions. So that, I think, is that coupled with what we're seeing here, that the intervention is it's not increasing their health risk based on either the HIV incidence data or the self-reported data, but it is associated with higher income, I think is also a clue for me that potentially this is a welfare enhancing intervention. We're not necessarily seeing that women are at higher risk of IPV. We actually did collect some data on mental health, so that's an interesting thing for us to look at, Maggie. We have not carefully studied those data yet. But my sense is that this sort of ability to learn partner status coupled with the ability to then make better informed decisions is something that generally for the women is welfare enhancing. But I would welcome like other people's takes on this issue as well.
So yeah, one more question, and then I'll see who has a question in the crowd. The subgroup analysis is really interesting, and obviously those effects are incredibly robust and strong and really interesting. I guess I completely understand why that is the definition, and sort of objectively, there, like empirically, there's a higher risk among that population. But what also makes me think about, especially in the context of what you're finding, is that people who are younger also maybe have less power and find it harder to speak up in these transactions. So if you think about this as like some kind of negotiation of how much risk to take on, and so one way to interpret those results is like, oh, it's a very rational, like super calculated, like, oh, I'm trying to maximize income and minimize risk. But another way to think about it is like, this is a population that has the hardest time with negotiation ex ante, and you're giving them another tool that is sort of more empowering. So yeah, I wonder, I guess I was curious, like, do these results look the same if you look only at younger women? I guess one way to think about this is there's higher risk. The other way to think about it is these are people for whom there's more power imbalance, or fewer tools to kind of, exert your own power, I guess.
Yeah, so I want to make sure, is your suggestion, should we look at even younger women, or because we're looking at,
I'm not sure. I was going to suggest looking at youth, like the youth of the women alone without the age differential, but then I think a similar issue comes up. So I'm not sure that solves the problem, but maybe just your quick reaction to that in general.
Well, I think just a very quick reaction there is that, I have been really struck by the size of those results, because exactly for the reasons you said, like you might think that for the very young women, they, even if they are able to initiate partner testing, that they may not have sufficient bargaining power to necessarily demand more income as well from that. But I think I was really struck by how large those effects are. We've, since the study completed, we've actually done a pilot, because my collaborator is very interested. Her sort of passion is about prevention among adolescent girls. So she's very interested in even looking at ability of adolescent girls, even 14 to 18, to initiate testing with their partners. And there's some pilot data suggests that it's actually feasible even in that young an age. But I think it's a good question. Like maybe maybe what explains it is that if you're able to initiate testing with your partner, that's a signal, first of all, that you have a lot more bargaining power, you have sufficient confidence to then also negotiate over condom use and prices potentially, right? So the women who are not able to partner testing may not be able, even if those women were able to somehow test their partner, there probably wouldn't be as much of a response to that.
Yeah, I would be curious, like, and maybe this is data that you could collect later, about eliciting beliefs around risk, and sort of getting directly at whether that is a differential, or if it does have something more to do with sort of power and tools for negotiation, and probably both. But anyways, I thought that was really intriguing. So I see a question from Dr. Manga. Salim, go ahead when you're ready.
Thank you, Doctor. That was a really brilliant intervention. I just want to congratulate the research team. I am a doctor without borders working in Mozambique, and I know how difficult it could be to perform the whole study since the design. So congratulations. And I want to ask you if you thought on dividing the study population between people who already know the HIV status. They will be more able to perform the HIV self-testing with a sexual partner. This is one question. And the other is, I didn't see differences in the PrEP exposure preventive therapy, but must be if we divide the population, the studied population, in people who already know someone with the HIV status, or if they already know they are HIV positive. Thank you for your answer.
Okay, so let me see if I can answer that. Thanks first of all for your overall comment, Dr. Manga. So the women, in all of the participants in the study, the women knew their own HIV status. They knew their own HIV status in part because we tested them at baseline. And I actually do think that's a really important point you're making, because in Uganda, Maggie, this is with Dr. Connie Kellum and others, they piloted a similar intervention with HIV positive women. We're actually finding that it's harder for women who are HIV positive and they know they're HIV positive to then also go home and initiate self-testing with their male partners, because often that's going to come with the natural question of, okay, well, I want you to take a test and reveal your status to me as well. So I think one of the reasons why we're seeing such high partner testing is that, to your point, Dr. Manga, like, I do think it's important that the women knew their own status, and all of the women in this study at the beginning were HIV negative, so it probably made it easier for them to initiate testing. So I hope I understood your question correctly, but there was no heterogeneity there in our study population. And then I think just to your second point, we are looking at PrEP data. So the study began in 2017, around the time when Kenya began to scale up PrEP availability. But take-up of PrEP in our study population was very low. So about 5% at some point during the study reported that they were taking PrEP. So I don't know that PrEP is necessarily playing as big of a role here. Certainly over time for an HIV prevention trial like this one, it would be important for us to make sure that what's driving these results is not necessarily some kind of difference in PrEP. But we also have checked, and we're actually actively working to publish the results, that the intervention does not in and of itself change the likelihood that somebody starts PrEP. There was another hand up.
Yes, Stacy, go ahead.
Hello, thank you. I just want to begin by thanking you for presenting your study with us today. I really enjoyed listening. And I joined the Zoom a few minutes late, so I apologize if you discussed this earlier, but I'm really curious about including male sex workers in this type of study, given that, engaging in unprotected anal intercourse is a really high risk factor for getting or transmitting HIV. And I don't have much context on sex work in Kenya, so would that even be feasible if there's not a large male sex work population?
Yeah, so it's a really good question. Actually, at the very beginning, I referenced some of the really seminal work that actually inspired me to do this study with adolescent girls and young women. It was done in the US with MSM in New York City and a few other settings. And I even spoke to the people who led that work with MSM in the US, because I think it sort of inspired me to do this work with adolescent girls and young women. To your question about whether this would also be possible with MSM in Kenya, I think yes, absolutely. And in fact, I'm talking to a team in Kisumu that works with MSM that is very interested in using self-tests and making self-tests available to them. So I'm not personally involved in a study that's happening with that population, but I think there's a tremendous potential for it to be piloted there. And I'm happy to follow up, Stacy, separately if you want to get some leads or information on that.
Thank you so much.
Sure. And definitely would recommend you check out the studies I referenced with MSM in the US, because I think they're really fascinating projects.
Yeah, that's interesting about the prep results too. So let's see, any other questions from the audience before we conclude for the day? Let's see any other for now. Thank you for the terrific, very comprehensive talk and showing these new results. I think they give us a lot to think about, and we really appreciate you joining us.
Thanks so much. Appreciate you being here. Thanks again.
Thank you.
Bye.
Bye, everyone.